Now, moving on to the next talk, I would like to introduce Drs. Sumit Grover from All India Institute of Medical Sciences to talk on low vision and rehabilitation aspects of vision impairment in children.
Thank you so much, Winston. Respected chair, and good morning to the August gathering here. I'll be presenting about the low vision assessment and rehabilitation aspects of child health, and there are no financial conflicts of interest. So we all know that this slide shows the WHO classification of visual impairment and blindness, and the term low vision, which was previously was there in the classification, has been replaced by categories 1 and 2. But what we are, the slides are not moving. But what we are interested is the WHO functional definition of the low vision, which states that the person who has visual acuity of less than 6/18 to the perception of light, but who uses or is potentially able to use the vision for planning and execution of tasks, which is the residual or the functional vision. And because of this definition, the people who were initially were categorized as blind now comes under the purview and the services to be offered to these people, low vision services to be offered to these people. As far as the prevalence and causes of low vision, prevalence of low vision in India is concerned, according to a study which was done in the southern part, the low vision was 2.9%, and the primary causes of low vision were refractive errors, which were of course mainly in the children, and the cataract in adults. These are some common diagnoses which we see. Perhaps this is a common scenario in the southern part of the India as well. So basically it's a whole globe in the retina, congenital disorders, retinitis pigmentosa, atrophic bulbi, high myopia, pathological myopia and its consequences, squint, congenital glaucomas, and then cortical blindness as well is on the rise. These are some clinical pictures. And when we, this is something which is interesting side, that when we analyze the cause of visual impairment from last four decades back, when we started our national program for control of blindness in 1976, when trachoma and cataracts were the main problem, and now when we look at the current scenario, the complex problems are here: ARMD, pathological myopia. So there are increasing complexities of the problem, and the resources requirements and the multi-sectoral integration is required. So that is how we are evolving, and that implicates that how this low vision and rehabilitation becomes important. So now, when we come to the assessment of the low vision, it's very brief slides and a very brief overview of this I'll be explaining. So first, when the child or a client enters into your clinic, we start from the history, and then we do the extent of the vision, near and distance visual acuity. And I want to emphasize that we have to be objective as much as possible. Like for example, we the optometrist or the ophthalmologist in the clinic, we tend to write the visual acuity in terms of finger counting, hand movement close to face, but it's okay, but we have to go objective. Like you should use the LIA vision chart or the Cardiff. As far as possible in these clients, we should objectify the visual acuity, and then size of the visuals as field by the confrontation method or the Goldman perimetry. Then what are the effects of light and glare on their eyes, on their working, extent of recognition of the faces, naming of the colors, and then extent of the use of vision for their activities of daily living, the purpose of their environment, whether they are in school, whether they are at their home, and extent to which the person sees and recognizes an object depends upon other factors as well, the familiarity of the object, light, size, distance, etc. And last but not least, the age, socio-economic condition, literacy status of the parents, and level of motivation of the parents is also very much important consideration. So when we do the best surgeries and everything, like beyond the best treatment, when the patient comes to us in the low vision clinic, so we should go for the history, which is very important. I have already mentioned that. Then the visual acuity, visual field, refraction, color vision and contrast testing, again on the objectively on the Pelly-Robson chart, and many other D15 color vision testing. These are very important. And then we move forward to the low vision aids, trial of low vision aids and counseling and education of the family and teachers, of course. So this is, sorry for the busy slide. This slide shows that how we start or approach a patient for the low vision devices. We should begin with the distance vision devices, like for example telescope, and then we move to the near optical device trial, and we should record the best visual acuity. And there are many methods of estimating the magnification of a particular for the particular child, and I'm not going to going into the details, but there are many formulas for that. And let the patient demonstrate the improvement of vision with each type of devices, and then we should take the comments on its utilization, the ergonomic, how the child is able to use or like kind of carry that low vision device. And then iteratively we should give another options to the child and the parents, and many a time such option may not be taken in one examination, so the repeated follow-up should be considered. And these are the this is overview of some basic optical and non-optical low vision devices, and like telescope, reverse telescope for the as a field expanders, then magnifying spectacles, and there are some advantages and disadvantages of these magnifiers, and there are hand magnifiers, stand magnifiers, illuminated, self-illuminated, etc. So this is the slide which shows the it's not working. Anyways, so this is the slide showing the self-illuminated hand magnifier. Then this is stand magnifier, in which the hands are free, and this is the okay, thank you. And bioscopic telescope, which is very much useful, and in some parts of the US it is also being permitted for the driving as well, and it is very sleek and can be fixed on the spectacles of the child. And then very important, these are electric magnifiers, which come in various forms and sizes, and these are very helpful, and nowadays many smartphones have replaced them for their usage. And now if we come to the low vision rehabilitation part, actually rehabilitation is an umbrella term in which the low vision devices prescription also comes, but just to compartmentalize from the low vision devices, now we are coming to the low vision rehabilitation. And in this purview I would like to talk about the non-optical devices like filters. Many a times we just focus on the low vision devices, but we forget about the effects of glare and especially in the albinism and RP patients, so, and role of controlled illumination, and then some kind of assistive technologies or products like typoscope, Notex. These things also should be offered to the for the child, and all these are based on the principle of big, brighter, blacker, and the closer color and contrast. Then there are mobility devices like canes and smart canes with the Bluetooth devices connected to the stick, and it can tell the child that how far is the obstacle, and the child is able to navigate smoothly. Then there are many medical assisted devices like talking watches, sensory substitution devices, and large print phones, large print playing cards, etc. And these can be locally made or can be purchased, and even the school teachers can modify the textbook and the things for the students in the school. Then the role of smartphones and the apps is worth mentioning. And most importantly, the environmental changes. Now we have a concept of inclusive schools, like a child with a visual impairment should study in a normal school, and the school has the responsibility to make it inclusive for that child. So there should be the braille writing should be there. For accessibility, there should be ramps should be there. All these things should be included. And then orientation and mobility training is very important, and the objectives are the safety of the child, independence, the privacy, the gracefulness. Sometimes we see the child with the severe visual impairment or the blindness, they're not able to make when they sing or they just speak, they make different gestures in their these things have to be taught to their parents, and these things should be highlighted and make aware that these are also by the training can be improved. And then these are some principles of the orientation mobility training. and uh, these are like we have a very good guidelines made by Dr. RP Center AIMS, and these can be procured from as a soft copy, and very important in these orientation mobility training. Now, especially in the children with the visual loss, we know that vision play a central role, and severe and profound visual loss affects the behavior and development skill of the child, cognitive function, socio-communicative abilities, then formation of social relationship with other peers, and education and employment. And vision rehabilitation in children needs attention as a, like we have two sets of intervention. One is vision stimulation. It improves by enhancing and changing the anatomy and physiology by stimuli in an artificial surrounding, like use of flashlights, use of many video games, etc., vision therapies. And but the results in the many studies were inconclusive, ambiguous, and very minimal responses are seen, because they tend to change like the neuroplasticity between the ocular structures, retina, and the brain. And but the functional vision training is like the rehabilitation part, when we give some objects to the child, make them familiar that this is the block, this is the card, this is your shirt, this is how you have to put on the buttons, etc. This is like sensory substitution. It is visual function training, which is very important for the child. This slide shows the RP Center model for rehabilitation services. At the hospital, which is our tertiary care hospital, we do the secondary and tertiary rehabilitation in the form of medical and surgical interventions. And then training and retraining of assistive devices is done in a separate wing, which is low vision rehabilitation wing on the 7th floor. We do activities of daily living training and orientation and mobility training. And then we have a social wing. There are spans of 17 vision centers which are spread across Delhi. And we do networking with the NGOs and schools for the blind, and community-based rehabilitation through our primary eye care centers. So this is called the medical socio model, which is being implemented at our center. And just two more slides about the assistive technology, that how we classify this assistive devices into two types at our center, based on visual, tactile, and sound based, and we classify them according to the visual acuity cutoff. Like for example, if a student has visual acuity of less than is more than 1/60, is with binocular best corrected visual acuity, so they are potential beneficiaries of assistive technology based on visual skills such as optical aids and large print books. But those who have less than 1/60, we give them assistive technology based on body sense using the functional vision learning. And these are some literature which is freely available in our in the website of Dr. RP Center AIMS. And last but not least, just a few things about the these smart glasses. I want to just show one thing. That this girl came to our low vision clinic, and for the first time she was able to see the face of her mother after so many years, and that was very much gratifying experience for the mother. It was very emotional thing for us. For the first time she was able to recognize the face of her mother, and this was possible because of the central vision loss onyx device. And this is the cost effect, like for the general population of India it is a higher thing, but now it has come down to 1.5 lakhs only. So that the purpose of these slides and to highlight these smart vision glasses, that there is a hope, still the hope, and we can counsel our patients and parents that they should not lose the hope. And sometimes it is by reflex or something like that. As a clinician, I'm also an ophthalmologist. As a surgeon, we say that nothing can be done now. Your vision is lost. You have a foveal dystrophy. Nothing can be done. You have the RP is there, advanced RP. Nothing can be done. So that is not the end of the life. We should instill the hope in the parents as well as the child, that there is many more things to done. There are low vision devices. There are low vision rehabilitation is there, orientation, mobility training should be given to the child, and the community based rehabilitation should be done, given to the child. And we have many assistive devices, assistive technology, we have smart glasses. So we should instill the hope in the child as well as the parents. So that was the crux of my presentation. Thank you so much for your patience.